what other type of patient besides bronchopulmonary dysplasia with tracheobronchomalacia, what other type of patient would you expect to see this instead of a nice round egg? You see this abrupt decrease in flow at the onset of exhalation. Asthma. Asthma is the correct answer. So patients with asthma have obstruction during inspiration and expiration, but predominantly during exhalation, and it's the same type of graphic, even sharper decrease in flow at the end of exhalation. And in that instance, not this one, but in that instance, you give albuterol, and the patient will change the shape of that curve to an oval.
Excellent. Okay, so we'll move on to the next patient. We won't spend too much time with this one, but this is going to be a very interesting case for all of you to deal with. And then after this, I'm going to move to my test lung. And I have a very, very, very sick asthmatic that I want you to help manage, okay? So this will actually involve you guys coming up to the ventilator and making adjustments on the ventilator. So don't be shy. So we'll move through this next patient here, and Jerry's going to assist me with this patient because they're getting pretty big now, and he's more comfortable with the big ones than I am. So this is an 18-month-old male that presented to the emergency room and has significant respiratory distress, is drooling, has biphasic stridor, so you can hear it without pulling your stethoscope out, has significant accessory muscle usage, active inhalation followed by active exhalation, and severe retractions. We attempt to use Heliox in this baby, and it seems to work quite well, but only at 40-60. So that's an FiO2 of 60% and 40% helium. Okay, it seems to work just a little bit, but it works much better when you have less of an FiO2 requirement and you can use something like a 70-30 mixture. So the SATs are 90%. The temperature is actually 39 degrees Celsius, and in the lungs you can hear stridor coming from the upper airway, and the breath sounds are very diminished throughout all fields. We get an X-ray.
Remember that this patient has a Y chromosome.
Yeah. So we get an X-ray, and this is what we see. So the lateral X-ray, and this is the AP. How many of you think this is a foreign body? I've given you all the clues, inspiratory and expiratory stridor. And then what do we see here? Is there something in the upper airway? Yeah, there's something in the upper airway. And it doesn't matter whether it's really in the airway itself. We have recently, we had a child that had a grape in the esophagus, and that compressed the membrane. So yeah, this child aspirated a watch battery. So the battery that you put in a watch, this child, toddler, picked it up and swallowed it and aspirated it into the lung. Very easily could be in the esophagus, but at the time we knew that this kid was compromised and we needed to do what we could to get it out. Huh? Yeah. Okay, so right here it's in the distal pharynx. And that will cause stridor just as well. I mean, it's compressing the airway or flopping the epiglottis down. Okay, so it's confirmed that the watch battery was removed from the upper esophagus. This patient failed extubation secondary to severe stridor, airway edema, vocal cord paralysis, and questionable aspiration. So there might be some reasons, and Jerry's going to elaborate on some of those reasons why a watch battery may cause all of this problem in this baby.
So this baby aspirated this watch battery, and what didn't actually get down into the trachea is probably was in the esophagus, maybe with coughing or whatever, may have moved more proximally. But if these watch batteries are in position for a while, they can actually set up an electrical current that can cause injury, resulting in fibrosis. I don't know if they can cause enough fibrosis, apparently they can, to actually cause nerve damage and cause the vocal cord paralysis that's also associated with the obstructed airway in this child. But probably both a scar on the trachea as well as perhaps some type of damage that compressed the recurrent laryngeal nerve on one side was responsible for the upper airway obstruction in this child even after the battery was removed.
And I believe that when the battery removed, there may have been just a little bit of, for some reason, it started to corrode. The battery started to corrode pretty rapidly, and they weren't really sure if there was some aspiration from some content leaking out. So moving forward, this child remained intubated for a day post-op after a failed extubation attempt in the post-anesthesia care unit. And so patients on volume control receiving 8 mLs per kilo, respiratory rates 35, PEEPs 5, FiO2s 45, and the PIPs 28. There's no arterial line. We have capillary blood gases that show that there's pretty good ventilation, PO2s in the 40s. The saturation is 95%. So how many of you have heard of the saturation FiO2 or SF ratio? I think Jerry's probably talked about it a little bit already. But the SF ratio is 211. Just file that away. Take your saturation divided by your FiO2. We don't have an A line in this patient. Can we diagnose them with ARDS or acute lung injury at this point? Well, we're going to move forward, and I'll let you know a little bit about that later. But remember, the SF ratio is 211. There's diminished breath sounds in the left lower lobe. There's crackles in the right. There's good cardiac function per echocardiogram. Temperature's elevated, and the patient was treated with antibiotics. So if we look at the X-ray, we can see that the endotracheal tube might be a little high, but we see that there's maybe some residual feed here. The OG tube looks like it's in a good place. Lung expansion looks pretty good. However, we're starting to get some perihilar infiltrates with this baby. And there's starting to be some infiltrates throughout the lung. It's not as clear as it looked before. So based on this, what would you say the patient's diagnosis is now? Do they have bronchiolitis obliterans, organizing pneumonia, BOOP? Do they have acute lung injury? Do they have acute respiratory distress syndrome? Or do they have acute cardiomyopathy with pulmonary edema? How many of you are going to say B? How many of you are going to say C? Okay, there are a couple of you that said C, all right? But it's interesting because there are certain diagnoses that we're using now to identify patients with acute lung injury and ARDS. Jerry Zimmerman happens to be one of the authorities that are trying to redefine the criteria for diagnosing acute lung injury and ARDS. But for now, the acute onset of the disease is a signal. This happened quickly. The X-ray is starting to show bilateral infiltrates. The LV function was really good. I mentioned that the echocardiogram was good. The PF ratio was 210. So does this patient qualify for ARDS, or does this patient qualify for acute lung injury? So there is some data, and Dr. Knuth and Robbie Kamani have at Children's LA have done some work and correlated the SF ratio, saturation FiO2 ratio, non-invasive measurement, to an invasive measurement looking at the PF ratio. And what they found is that the SF ratios of 263 and 201 corresponded to PF ratios of 300 and 200. All right, so.
You want to just go back to the 2 slides back to look at the chest X-ray again? So the other thing that's notable about this chest X-ray is that he's pretty hyperexpanded. The tidal volume on this patient was 11 mils per kilogram. And I would say the cardiac silhouette's a little on the small side. So I would guess if we looked at the patient's dead space ratio by looking at end-tidal CO2 and carbon dioxide in the blood, that this child's dead space is increased, that there is lots of West Zone 1 lung and that this patient's pulmonary blood flow could be improved by either decreasing the mean airway pressure or providing this patient with some way to increase blood flow through the lung, like some volume resuscitation, replacement, or some inotropic support.
Very good. Okay, so we kind of know where we're going. We know that saturation FiO2 marker may be very reliable for determining whether the patient has ALI or ARDS based on these values over here. We know PF ratio, less than 300 is ALI, less than 200 is ARDS. However, if we can measure saturations, we know that 263 corresponds to 300. So if the value is 263 or greater, or lesser, sorry, then they may have ARDS or ALI, and less than 201. That one actually corresponds quite nicely to the ARDS value.
So remember, if you're going to use these definitions where you employ saturation instead of PaO2, that you need to wean the oxygen enough so that the saturation is less than 97%. If you recall the relationship between PaO2 and saturation, it is a curvilinear relationship, and above about 97%, the line is essentially flat. So in order to have this consistent relationship between PO2 and saturation, you need to be on the linear part of that curve, and so the saturation needs to be below 97%.
Excellent.
Look up Robinder Kamani and get some of his latest papers, and that's explained very nicely. But it's a nice thing to know because you don't need an arterial line to make this determination.
Excellent. So what will we do? We know that this patient has some form of acute lung injury. So do we treat them differently, or do we keep doing what we're doing? So let me ask you, would we place the patient in the prone position? Would you reduce the tidal volume and place an A-line? Would you place the patient on nitric oxide at 20 parts per million? Would you place them on veno-veno ECMO with resting lung settings? B? C? C? Some of you guys are saying C. Now, look at your settings. Your peak inspiratory pressure is approaching 28, and the tidal volumes are 11 mLs per kilo. So if we look back at the adult studies, anything greater than 30 for a peak inspiratory pressure or plateau pressure greater than 30 or 35, we start to worry about there being lower lung compliance for a given volume. So I think it's sufficient to actually reduce the tidal volume. And now that the baby or the child's getting sicker, you may want to place an arterial line because you may need to use some hemodynamic drugs, some vasoactive drugs that you need to evaluate blood pressure and PaO2 a little bit better. So here's the recommendations right here for managing patients in the pediatric intensive care unit, and this is based on a lot of Adrian Rudolph's work. And of course, we're extrapolating from adult practice, and we're using some of the conventional wisdoms that we've developed managing these patients with conventional mechanical ventilation. Keep your plateau pressures less than or equal to 30 centimeters of water pressure. Well, how do you get a plateau pressure? You do an inspiratory hold when the patient is in a volume control mode, or even if they're in pressure, you do an inspiratory hold, because at that point, flow goes through zero. So the pressure in the circuit and the pressure at the airway is all equal to the pressure in the alveolus. We never really want to have a plateau pressure greater than 30. All right, so avoid tidal volumes at all costs greater than 10 mLs per kilo, and that's based on the ideal body weight. So we tend to adapt our strategy and use 4 to 6 mLs per kilo for these children. A good place to start would be 6 initially. If the plateaus continue to creep up, then you need to reduce your tidal volume. But as you reduce your tidal volume, you need to keep in mind that you're affecting your overall alveolar minute ventilation. So you may need to turn your respiratory rate up to maintain carbon dioxide, or you may choose to let your CO2 rise a little bit. That's known as permissive hypercapnia. So the pH goal, we tend to accept lower pHs. These patients will eventually potentially need more sedation, but we try to avoid that at all costs. There's some evidence that we do not recommend the routine use of inhaled nitric oxide or prone positioning, okay, in these patients. I know that some folks do, and that's great, but we haven't had great success with prone positioning, mainly because we worry about the endotracheal tube dislodging. But it's nice to have these beds now that are going to turn. We have these beds that turn and will move things around. There's also a PEEP FiO2 ladder that a lot of us have begun using in supporting children with ARDS and ALI. It's always been told to me that if you're on 50% FiO2 and 10 a PEEP, then about half your lung is open. And if you look at CT scans of piglets, that holds true to this day, that if you're on 50%, you can always remember, if you're on 50% and 10 a PEEP, about half of your lung is open. Okay, meaning that there's areas that are being ventilated and then there are areas that are completely collapsed, and that's usually in the gravity-dependent section. In most cases, it's when they're laying on their back. So it's important, we need to escape this whole PEEPophobia. We need to start to use suggested PEEP settings. So if you're at 60% FiO2, it's suggested that you keep the PEEP at 10. If you creep up to 80% FiO2, it's suggested that you increase the PEEP to 14, because you want to be able to overcome intrapulmonary shunt. And the only way that you're going to do that is to use higher PEEP levels. Don't be scared. You're using smaller tidal volumes. You can use higher PEEPs. You would do that with the oscillator. You would turn the mean airway pressures way up. Well, it's time to start using the ventilator a little bit more appropriately, and so we're starting to do this a lot more in the ICU.
So for some reason, people are not afraid of the oscillator, but they are afraid of using high PEEP, and they're really the same thing. The oscillator, there's no PEEP that you measure because it's a mean airway pressure that's constant all the time, basically, with just fluctuations around that mean pressure. But for a conventional ventilator, don't shortchange it by using too low of a PEEP, because your mean airway pressure will be low also. So you need a high enough PEEP to keep that lung open during exhalation, and this will give you a higher mean airway pressure.
It's amazing. Ever since we started using this approach in our pediatric intensive care unit, and we also use esophageal manometry. And by using esophageal manometry, we know exactly how much pressure is being delivered into the lung because we know what the transpulmonary pressures are. We found that we're using much higher PEEP levels. In fact, we had a kid a couple of months ago that was on 22 of PEEP, and that's the highest that we've been in a lot of these kids. But a lot of these kids are the size of the adults, and they have super stiff lungs, and we're finding that, yeah, we can, in the PICU, start to use pressures greater, PEEPs greater than 20, and they're fine. In fact, they're much better. But only use those high PEEPs when you're using a low tidal volume strategy. Okay, so this kiddo, after 24 hours, starts to develop severe arterial hypoxemia with worsening. Now the kid is this kid's developed ARDS. We're in volume control. The tidal volume 7 mLs per kilo. The PIP is 34. The plateau pressure is 32. The PEEP is 12. The FiO2 is 70. The blood gas is slightly acidotic. PO2 is 65. SAT's 92%, and this is on 70%. So the breath sounds a decrease with fine crackles. Here's your x-ray. So this is a patient who clearly has deteriorated and now has developed severe ARDS. All of you would agree. So what would you do next? Would you reduce the tidal volume to 4 mLs per kilo and turn the PEEP to 10? Would you increase the tidal volume to 8 mLs per kilo and the respiratory rate to maintain PaCO2 less than 55? Would you implement Heliox at a 40-60 mixture, or would you decrease the tidal volume to keep the plateau pressures less than 30 and increase the respiratory rate to keep the pH greater than 7.30? What's the best answer? A, how many of you would do that? B, C, D. D? A? Okay, only one person answered. You guys are, I need your help. This baby's getting sick. This child's getting sick. And I really need your help here. Here's your settings. Rate of 40, 7 mLs per kilo. Plateau pressures are 32. Okay? PEEP's 12. FiO2 is 70. And here's your blood gas. PO2 is 65. C? How many of you think C? Don't do anything? Don't just do something, stand there. Have you ever heard that saying? Don't just do something, stand there. Okay, so a lot of you are saying B, increase the tidal volume. I probably wouldn't increase the tidal volume because my plateau pressures are greater than 30. We did an inspiratory hold. If your plateau pressures are greater than 30, are we ripping the lung or are we protecting the lung? We are ripping the lung. We're over-distending the alveoli. We're putting them at great risk for alveolar over-distension. Okay, so do we want to keep the tidal volume at 7 mLs per kilo? Or do we want to reduce the tidal volume to keep the plateau pressures less than 30 and increase the respiratory rate to keep the pH somewhere around 7.30? The reason why I mentioned increasing the respiratory rate here, this is the correct answer, D. And the reason why I say increase the respiratory rate, because if you turn your tidal volume down, you're reducing alveolar minute ventilation. Okay? So always remember that you may sometimes need to turn your respiratory rate up to maintain an adequate alveolar minute ventilation.
And almost certainly you would also increase the PEEP. So you want to get those alveoli recruited, and based on that FiO2 PEEP ladder, a patient on 70% oxygen should probably be on 12 or 14 of PEEP, not 10.
Yeah.
So the PEEP for the oxygenation, turning down the tidal volume to avoid volute trauma, and increasing the ventilator rate to take care of the higher carbon dioxide that's going to occur because the tidal volume is reduced.
Okay, we have a couple more slides left. A lot of you were asking earlier about, how would we manage a patient who's failing an approach like this? So this patient is being managed by this ARDSNet approach, and I would suggest to every one of you to manage your patients this way that have acute lung injury. Even in the early stages, if they have ALI based on the saturation FiO2 ratio, I would manage them this way regardless. Volume control or PRVC, or even if you're just using pressure control, make sure those tidal volumes are within that range that we mentioned, and make sure that you start to use your PEEP appropriately. Now, in this particular situation, the patient got very sick and the oxygenation index went up to 29. That's a relatively high OI. We don't know what the oxygenation index is that we should limit patients to conventional ventilation or high frequency ventilation. But that measurement is based on your mean airway pressure, FiO2, your PaO2. So the gas exchange isn't horrible except for the PO2, and now we're on 80% FiO2, the PEEPs of 15. Our plateau pressures are still quite high despite using a tidal volume of 4 mLs per kilo. So that's the low end for larger pediatric patients. Never go below 4 mLs per kilo. So the breath sounds are diminished. What would be your next step? Initiate high frequency at a mean airway pressure of 27 and a delta pressure of 40, Hertz of 8. Initiate high frequency oscillatory ventilation with a MAP of 22, a delta pressure of 18, and a frequency of 4. Administer continuous albuterol. Or reduce your tidal volume to 3 mLs per kilo and increase the respiratory rate to keep the pH greater than 7.30. A? How many of you say A? B? Okay, there's one. Okay, A. Why would we manage them here? Why would we start the mean airway pressure at 27? Because you always, in these larger patients, are going to start your mean airway pressure 5 centimeters of water pressure higher than the mean airway pressure on the ventilator, right? And in this particular patient, we're starting the frequency around 8. That's a little low, but that's okay. And we'll set their delta pressure at 40 because that's what it takes sometimes in these larger kids to get them to wiggle. And we want their wiggle to be from where? The top of the shoulder to the... Okay, the umbilicus is the baby, but this is a bigger kid, so... Thigh. Okay, good. We want them to be able to wiggle like we said earlier. Okay, good. So you place the patient.
So
Yep.
can you go back? Just to be the devil's advocate and to be fair, you're going to manage this patient now with a mean airway pressure of 27. The mean airway pressure before was, where is it?
22.
Next slide. Nope.
Whoops.
Well, the mean airway pressure was less than 27.
22.
So
Yeah, 22.
22. The mean airway pressure was 22, and you're going to manage the patient with a mean airway pressure of 27. So if you were comparing these two strategies, this is not a fair comparison because you're giving more support with the oscillator. And in fact, and I'm not arguing against the oscillator because we have lots of experience with it, but there's never been a really good study in pediatrics comparing the oscillatory ventilator with conventional mechanical ventilation using comparable settings. There just have been 2 studies published in adults comparing conventional mechanical ventilation and oscillatory ventilation head-to-head with similar type of support, and there was no difference in terms of long-term outcomes, mortality. So we use the oscillator, we're familiar with it, but I think we're still afraid to use a PEEP like we probably should.
Yeah, I agree completely and wholeheartedly. They did find in that study that a larger majority of the adults, I mean, there were a couple of larger pediatric patients included in the study, but they found that they needed more neuromuscular blocking agents to remain comfortable. And as such, there was borderline significance in increased mortality. I don't think it ever really reached statistical significance for a difference, but I think what we're going to find now is that, based on the editorial, high frequency is on shaky ground, at least with the adults, because they did use best practice lung protective ventilation strategies, looking at plateau pressures and low tidal volume, high PEEP, and they compared that to early initiation of high frequency oscillatory ventilation. And really, it didn't pan out very well. I think that major reason why patients do better is because we do use higher mean airway pressures, and that promotes gas exchange, like I mentioned earlier, and opens the lung. And in a PEEP-ophobic environment, like the pediatrics and neonatology, then this takes it to the next level because we're able to use a higher PEEP level, but only because we're using smaller tidal volumes. Okay? So let's look at the x-ray after 24 hours of being on the oscillator. And of course, Jerry came along and did some massive fluid diuresis over 24 hours, and the lungs look much better. We note that the patient's chest wiggle was pretty excessive. What would you do at that point? I'm just going to make something up right now, but what would you do at that point? What would you do? Reduce delta P, that's what I would do. And I would do that until you get a chest rise that's not too excessive, and then you may or may not decide to get a blood gas after that. That's up to you. So in these patients, high frequency is usually initiated as a rescue form of therapy when they fail conventional. Compare with conventional ventilation, high frequency initiated earlier in the disease process may improve gas exchange, reduce barotrauma in pediatric patients with ALI, ARDS. And that's based on a very old study. It was one of the only studies that randomized patients to conventional ventilation. Who knows what they were doing for a conventional ventilation strategy to high-frequency oscillatory ventilation. That's all we really have to go on. There are more studies, like Jerry mentioned before, that need to be conducted, prospective randomized controlled trials that enroll patients to best practice conventional ventilation, best practice high-frequency oscillatory ventilation. You guys did a wonderful job for this part, and I want to thank you. So now, I don't know who's running the show at this point, but this is going to be fun. This next part is going to be really fun because we have an actual patient over there, and her name is Ingi. The Ingmar ASL 5000 is a $35,000 test lung simulator that I schlepped all the way from Seattle to here and got stopped a number of times, but luckily they didn't call me into the little room this time and put the glove on. So now I've got the test lung here. I'm going to start this up as soon as I'm told that we're okay to do that, I think we can go straight to it. It might take me just a couple of minutes, so if you needed to take a quick break, go ahead and do that. But please come back, because this is going to be very interesting, because we have a 12-year-old girl with severe status asthmaticus that's in the emergency room, and they want to send him up to us to the PICU. So I'm going to need your help. So if you can come back in, what's the time? It's 5 now? It's 6:30. Oh, so we should do that. So we can't do it. Okay, let's do it quickly. Try not to leave. If you have 20 minutes of time, that would be okay. Do we have time? Okay, can you get the ventilator to hook up to the LCD? Has severe labored breathing, and she came up. She is on Heliox, and we've tried non-invasive ventilation with her, and she is severely and profoundly hypercarbic on the mechanical ventilator. And we've just intubated her. Bear with me just one moment. Okay. So this 12-year-old girl, you can see airway graphics here. Oh, is it still doing it? Yeah. So we're being supported with a respiratory rate of 25. Tidal volume is 500. And let's see what our weight is real quick here. Yeah. So that's a 50-kilo kid, big kid. And we are receiving volume ventilation. Let me just come in here real quick and make one more change. Okay. Let me just make sure that this thing's going. Okay, I think because I left it on, I'm going to disconnect this real quick and power it back up again. Where's Jerry? Jerry, tell them a little bit more about this 12-year-old girl and how we managed her in the emergency room with status asthmaticus.
So probably this patient, this would typically be a male who has asthma and is getting worse, and instead of going to see his doctor and getting put on some steroids, just is increasing his albuterol dose. And so now, instead of taking it as needed, is probably taking the albuterol every 6 hours, then every 4 hours, and before he's coming into the hospital, he may be taking his albuterol every hour. He would be put on continuous albuterol, as he would be probably anywhere, probably given steroids. If he wasn't so sick, maybe enteral dexamethasone, but as sick as he is, probably an IV would be placed, and he would be given a dose of 2 milligrams per kilogram of methylprednisolone. And then because of
Heliox was tried on non-invasive ventilation.
so he was because of his sustained increased work of breathing and probably poor airflow on auscultation and likely very high carbon dioxide, I would guess, on a blood gas initiated on non-invasive mechanical ventilation to try to assist with his work of breathing. And then the other trick that can be used is to try helium-oxygen mixture, particularly if there's not a large inspired oxygen requirement, because this can improve delivery of the albuterol to the more distal airways where most of the resistance in the pulmonary conducting airway is. So the Heliox was initiated, the continuous albuterol was probably maintained, but this child's work of breathing persisted. It is likely that he was also administered one or more boluses of magnesium sulfate as another direct, smooth muscle relaxant, again in an effort to get some bronchodilation, improve gas flow, and reduce work of breathing, and improve ventilation to reduce the carbon dioxide level. If all of these had failed and the patient was ineffective in ventilation and perhaps fatiguing with the carbon dioxide increasing further, this would be a decision point to intubate this patient. And so this is I think this is one of the most dangerous situations when you go to intubate somebody. Because the patient already has an acidosis that is secondary to ineffective ventilation, probably has on top of that a metabolic acidosis because of the severe increased work of breathing. The oxygenation may be somewhat marginal, and there is a lot of catecholamines being given to this patient in the form of continuous albuterol. So the heart may be under considerable stress. So this is a patient that you need to be ready to do the intubation quickly with a good person and utilize a good technique so you can get the tube in. Because I can tell you that regardless of what you can do with the ventilator, what that person is doing right now through millions of years of evolution is close to the most effective way that that person can breathe. The tidal volume, the rate, everything about that breathing pattern is designed to be as effective as it can be, and it's still not working. So when you put this patient on the ventilator, you're going to have to be very clever to do a better job than Mother Nature. So does anybody have an idea of what sedative you might use to intubate this patient? What would be a good choice? Ketamine would be a good choice because it is a bronchodilator, and sometimes we use this for sedation as well in these patients. So anyway, Rob, the patient does get intubated?
Yeah, so this patient's now intubated. Patient's being supported with a rate of 25, and the end tidal CO2 is around 45, 46. The tidal volume is about 481. Now we set a flow rate in volume control mode to get a particular inspiratory time. So the I time is 0.64. The IDE ratio is 1 to 2.7. And the child's on 6 API. And the flow trigger, I'm going to reduce that just a little bit to about 1. And of course, this child is on 100% oxygen, but we don't have the ability to give 100%. And I will spare you with the alarms and keep it at 21. Okay, so I want you to observe the flow time scaler, and I want you to observe the pressures and all of these things, and kind of tell me what's going on with this child. I'll give you a hint. The breath sounds are nearly absent throughout. She's receiving continuous bronchodilator therapy. All right, or I'm sorry, she's receiving continuous Heliox therapy. We haven't given any bronchodilators yet. But please tell me, in this mode of volume targeted ventilation, tell me some things that are very interesting about the flow time scaler. So I'd like you to participate. Please tell me about the pressure and the flow. Do those look normal? I can't hear you, sir. Sorry. We gotta speak through.
Autopay is generating in this patient.
Okay.
Because the expected limit is not reaching till 0. Before that, the inspiration is getting started. We we can increase the expiratory time. We can increase the expiratory time.
Increase the expiratory time. So why don't you come up here, please, and let's increase the expiratory time on this mechanically ventilated child. So you want to reduce the inspiratory time? So we'll go up on the flow rate. There you go. Very good. Let's turn our flow rate up. Yeah, he's still not exhaling back to flow. But this is the rate that we need to maintain ventilation in this child. Is there anything else we can do? Do we know that this patient has auto PEEP? We just assume that this patient has auto PEEP, but the flow's not coming back to zero. Decrease the rate? Okay, but the CO2 is really high. Is that okay? Pay attention. Let's back up for a second. Let's look at our inspiratory pressures. Our inspiratory pressures are super high. Notice they're 70. Those pressures are 70 to move that tidal volume. Is that okay? Pressures of 70? Well, I want to show you a little trick real quick. Is this an alveolar problem or is this an airway problem? Okay, it is an airway problem. And one way that you can separate this in your mind for all of your patients is do an inspiratory hold. You're in volume ventilation and we're getting pressures of 70. Let's do an inspiratory hold. Okay? I'm going to freeze that screen. Where's the freeze button? Freeze. Okay? Now let's look. If my inspiratory pressure, oh, it's 90. That inspiratory pressure is okay for that volume because the alveolar pressure is about 40. Okay? So we mentioned before that alveolar pressures greater than 35 are going to be a problem, right? So instead of reducing your rate, what is something else that we can reduce? Tidal volume, because our plateau pressures are greater than 30 something. But this is kind of a nice approach because rather than dropping your rate, we are overextending the alveoli. Even though there's a huge disparity between the inspiratory pressure and the plateau pressure, if a patient had an alveolar process, there would be no disparity. The plateau pressure would equal the alveolar pressure. But in this case, we know that there's a difference between peak inspiratory pressure and alveolar pressure. We know it's an airway component, however, we're still overextending the lung. So let's drop our tidal volume a little bit. Let's drop our tidal volume. I'll let you drop the tidal volume a little. Okay, that sounds good. Let's set that. There you go. Are we going to chase it by increasing the respiratory rate? Probably not. Okay. Let's actually come along over here now. Let's pull something else up here because most of the ventilators have this now. Let's get the auto PEEP measurement up here. Do you know how to get an auto PEEP measurement in a kid with asthma? Do we do an inspiratory hold or do we do an expiratory hold? Expiratory hold. And this only works when your patients are passive. Okay, in a spontaneously breathing patient, the only way that you can measure auto PEEP is to place an esophageal balloon cap. Okay, so we're going to come along. Let's turn our volume back up again then. Okay, we're about 482. Let's do an expiratory hold. Okay, there you go. We did an expiratory hold. Now we're going to freeze the screen and let's scroll over here. This is your auto PEEP. It's 25. Your auto PEEP in the lung is 25 centimeters of water pressure. Is that okay? Okay, so let's now that we know what our plateau pressures are, we know that we should probably drop something. Because even though it seems counterintuitive to drop your tidal volume or drop your rate, your CO2 could improve because you're now allowing more time for the patient to exhale. All right, so now that we know that the auto PEEP level is 26, let's come out of this screen, go back to ventilating this child, and now let's wean the tidal volume because we know the plateau pressures are absolutely high. Okay, so let's wean our volume. You were weaning that, weren't you? All right, there you go. Let's give him a few breaths. Let's give him 5 or 6 breaths or a little bit more. Yeah, we're still gas trapping quite a bit. Let's go up on my flow just a little bit more. Is that okay? Yeah, because higher flows are going to be higher peak inflation pressures, but at zero flow. Let's do another inspiratory hold. degrees. So we dropped our tidal volume. Look at that. Those plateau pressures are now about 32. And that's okay. They're less than 35, so we're not over-distending the alveolus, right? Good. So we're in a good place there. Let's give them another minute here. And I want you to do an auto peak maneuver for me. Someone else come on up and let's do, thank you, thank you. You're doing a good job with this patient. She's getting there, okay? Who wants to come up and do an expiratory hold for me? I want someone to come up, please. Somebody? Anybody? Come on up.
Rob, can you show us the flow versus volume loop on this?
I will. Yeah, I've got that all figured in here. The age of this child, 12. Let's actually do an auto peep maneuver. Do an expiratory hold.
The peep, reduce the peep.
We're doing an auto peep maneuver. Yep. We want to find out if our auto peep has gone down from 26. That represents the intrinsic peep level. There's all that pressure that's in the lung. Let's do an expiratory hold. Okay, hold this button down. There you go. Hey, push it. No, you gotta push the button. There you go. Okay, good. All right, that's good. You good. There we go. So let's see here. So it went from 26 down to 20. So we're getting there, right? We're getting closer, right? Now, what are some other things that we could be doing right now? I know you all want to wean that rate, and I agree with you 100%. But there are other things going on. This patient's sick. Huh? Ooh, we're going to wait for that in just a minute, okay? I would increase the peak too, but I talked for an hour this morning about certain things that you give to patients that are on a mechanical ventilator. What's that? One at a time? What's that? No. What are some things that we can provide to the patient that's mechanically ventilated? Aerosols? Is that okay? We're humidified, very good. But what about inhale bronchodilators? So let's start to give an inhale bronchodilator because that takes some time to take effect. Of course, we're going to wean that rate, but let's just try something first. And I want to call to your attention this here, flow volume loop. Okay. Like Jerry said earlier, let's observe this flow volume loop. Breath goes in nice. On exhalation, the airway closes, and then I want you to prepare an albuterol treatment for me. Tell me where you're going to put that albuterol treatment. Are you going to put it at the humidifier? Are you going to put it at the patient? You can ask your friends. Go ahead.
Patient.
Okay, so as close to the patient as possible, right?
Yeah.
So I want you all to take a look at the flow volume loop. All right? So we're giving the bronchodilator treatment.
Yeah.
And if we look at our flows, that is a very, very abnormal flow volume loop. There's significant gas trapping. This is supposed to look kind of like a football. It's not supposed to look like Africa. Okay? So we give the bronchodilator treatment, pay attention to that flow volume loop. Bronchodilator's going in. Okay, my lung model's not responding to me. But what you would expect in a particular patient like this is that breath goes in, and then on exhalation, the flow volume loop is going to open up. And rather than having collapse, you would have gas return back to baseline rather quickly. For some reason, I can't get the lung model to do what I really want it to do, but that's what you would expect with a bronchodilator. Now, we still have a problem, okay? We still have gas trapping based on our flow time scaler. Blood gases come back in the CO2s in the 50s, pH is around 7.30. What is our next step? The bronchodilator clearly didn't work in this particular patient. All right, we need to get this kid steroids as soon as possible. So what would we do at this point? Yeah, so we can't really manipulate the inspiratory time any longer, so what would we manipulate? Reduce the rate. Okay, so you're going to reduce the respiratory rate. Go ahead and let's drop that respiratory rate. Right here.
So the other thing is perhaps this bronchodilator, the albuterol, is not getting to where it needs to be. So is there any other way you can deliver a bronchodilator? And what do you use here in India? Terbutaline or salbutamol, isoproterenol, some form of intravenous beta-2 agonist is what you could add on top of the nebulized treatment. And this is what we would do if this patient was still air trapping on these high ventilator settings at risk of pneumothorax. That's what we'd be worried about. If this child has a pneumothorax, there's going to be big trouble very quickly. So that's why we want to fix this air trapping. And while we are figuring out what to do next on the ventilator, it would probably be wise to get some intravenous terbutaline or salbutamol or isoproterenol going in addition to the nebulized albuterol.
Okay, so I'd like to focus your attention now to the flow time scalers. Dr. Laxman is going to manipulate the respiratory rate because that's all we have left. We tried bronchodilator, we reduced the tidal volume, got him in a good range. We still need to ventilate the kid, but we do have some leg room. So let's reduce our respiratory rate. Okay, I wouldn't go much beyond that. Okay, go for it. So our last auto peak measurement was 21, right? So look at that. So now we have a little bit more time for exhalation to occur. And it looks like your carbon dioxide levels, if you ever, how many of you use end-tidal CO2 here? You have a way to look at that? So what would your end-tidal CO2 waveform look like? Would it look like a square? Or would it look like, and then come down? A square? Well, in kids that have severe airway obstruction, one way you know that they're having a difficult time emptying their lungs, and there's a lot of, you'll look at your end-tidal CO2 capnographic waveform, and it will actually go like that. It'll kind of sculpt upward, and then exhalation will occur. That's something that would help signal airway obstruction. So we've actually dropped our respiratory rate, and surprisingly, the blood gas comes back and the CO2 is lower. That doesn't make any sense. We dropped the rate. Okay. Well, this is one of those complex patients where you drop the respiratory rate and the ventilation improves because you're allowing more time for exhalation to occur. Okay, one of you mentioned going up on the peak. Give me just one more minute. We'll wean that respiratory rate just a little bit more, but not much more. Okay? So let's get another auto peak. Let's do an expiratory hold in just a minute. There you go. Hit it. Push, push. Okay, good. Good. We'll freeze the screen. We're going to scroll over. And look at our auto peaks down to 14. That was 28 when we first started. You've cut it in half simply by reducing your tidal volume based on your alveolar pressures and by reducing your respiratory rate. And maybe by now there was some effect of your bronchodilator. So now I think that's a big deal, and I thank you very much for that. Fixing the patient. So that's good. We're managing this patient pretty well. However, I'm going to do something a little bit different here and hope that this is going to work. Acutely while you are providing this initial adjustment of the ventilator, but
as soon as you can. These patients will probably have the best lung mechanics if you put them in a pressure support CPAP mode where they can determine what is the best rate for them and then adjust the pressure support to give them the tidal volume they need to achieve adequate, not perfect ventilation.
Bear with me for one more second. For some reason, Ingi doesn't like India, but it just takes her a little bit of time. Sometimes when I make these big changes in compliance or resistance, it senses an error. So we'll get this running here in just a moment. So like Jerry was saying, this patient has been sedated and paralyzed for some time now, right? But pardon me for one moment. Well, oh, there we go. For some reason, my computer's frozen. But I can assure you that this patient, if you just, do you have a Tesla anymore? Anyway, in this particular patient, there's good data available now. Kit Newth, Dr. Newth from LA Children's found that if you take patients out of SIMV or out of assist control ventilation and you put them into pressure support and you allow them to maintain their own inspiratory time, that their work of breathing can be reduced tremendously. But what he also found is that using higher levels of pressure support can offload the respiratory effort. Furthermore, using higher peak levels, I'm not talking about like 5 or 6, I'm talking about peak levels up to 14 centimeters of water pressure. By using those higher peak levels, you will actually reduce the airway resistance and degas the lung. So I've actually seen patients that were breathing spontaneously in pressure support and liking that much better than conventional mechanical ventilation. But by placing them in pressure support, of course they're breathing more on their own, they have to trigger every breath. There are some patients on pressure support where they will initiate a breath, but they'll never actually trigger the ventilator. And it's very uncomfortable for them to not get a breath when they want one. And that's because you must first overcome the auto peak in the chest in order to cause a pressure change in the circuit that's sufficient enough to trigger a mechanical ventilator. So by turning your PEEP up, turn that PEEP up, just keep going, look at your blood pressure, look at the work of breathing, and eventually you will equilibrate the set PEEP level with the auto PEEP level and reduce the airway resistance to a point where they can actually trigger the ventilator. So a lot of people are using NAVA to avoid using higher PEEP levels, but trust me on this, asthmatics that are very sick, even broncholytics that are very ill, if you turn your PEEP up, don't be PEEPophobic, turn it up, you see that they're not triggering the ventilator, there's an effort, but there's no change in pressure enough that can generate a breath, turn the PEEP up, and it will help. Okay, so that, I think, is going to conclude our session today. Thank you very much for managing this patient and all the other patients. I hope that was helpful, and we'll see you tomorrow. Thank you.